We'll move on. We're going to start with talking about, a lot of times when Rich and I are out lecturing and when people call DS3 and ask questions, one of the big questions that come up are, can we do this? Should we be doing dental sleep? And in particular, should we be helping our patients get sleep tested? And we've had opinions for that for a long time. But now there's some organizations that are, making that a little more clear from their standpoint. And the ADA, I think, came out with October, right, Rich, with finally making a position on this.
Yeah, I'm really happy to see them step up to the plate, Guy. Because I know a lot of you dentists out there are thinking, well, I don't know, man, if I should be doing this, it could change people's bite. It could do this, it could do that. But, the ADA is saying you should be screening your patients. You make the appropriate referrals. You do this, and we make them dental devices. And then, as you pointed out, Guy, before anybody could hear us, the last part of that is it's okay to use home sleep testing monitors on the back end to make sure our dental device is working. So I'm really glad to hear that that they're stepping up to the plate and this is happening.
Yeah, I mean, we should be screening and we should be getting our patients tested, helping with that. We should certainly, if we're going to treat these patients, follow up with some sort of testing to make sure that just because they quit snoring, that doesn't necessarily mean where we need to be. And now the American Academy of Dental Sleep Medicine, that's another organization, and they worked with the American Academy of Sleep Medicine, the AASM, and they looked at the studies that were out there, how well CPAP's working, and a lot of various studies, and they came up with a 50-something page report, which we'll summarize for you in the next few slides. But what they found, I think, even though we know CPAP works and everybody believes it works well, what we're concerned about is that 83% of the patients may be non-adherent to CPAP through the studies of 2015. And then when we're looking at how well it alleviates the disease or the actual medical ramifications of the disease, oral appliances may be comparable with CPAP due to this non-adherence. And so
let me add one thing to that, Guy. Back up that slide.
Sure.
That 83% aren't using it. Remember, Guy, that was only 4 hours a night. You didn't have to use it all night. Right. So 83% of the people aren't using it at least 4 hours a night. And that's why we know that our patients will wear our dental devices most of the night. And that's why this next slide that you have, Guy, I think shows that we make up some of that difference.
Yeah, I mean, if you're looking at the overall effectiveness versus compliance, and this is a graph and study have been around for years, but I think we're really starting to pay more attention to it. We know that the CPAP, which is in the orange line here, does a little bit better job of getting air to the airway and lowering what we call the AHI. But when we look at, will the patients wear it? How is it good for the bedtime partner? How well is it tolerated? And even the health benefits of dental devices, they're about the same. So when we look at the black line here, and we look at the orangish line, that's the orange is CPAP, and the black line is dental devices. Overall, when we take all these factors into consideration, dental devices certainly have a place, if not even satisfy more of these criteria than CPAP. And I think that's some of the basis where they came up with the 2015 practice parameters, which, again, if anybody wants a copy of those, we can show you where to get the 50-something pages. We'll give you our contact in a bit, and by all means, we'll be happy to get that to you. But the summary is really down to about 6 points that really show that dental devices have a place in conjunction with CPAP.
Yeah, and the first one, Guy, says physicians should prescribe an oral appliance just for people who snore. So there's enough data out there that says if you just snore, there are some things going on in the epithelial cells of your heart and all this other kind of stuff. So, you got to use a custom device. The over-the-counter ones just aren't working. They won't stay in people's mouths. And, for patients who can't wear CPAP, well, obviously that makes sense, that we should put them into a dental device. But that's half of it right there, Guy.
Yeah, and I think one of the things that comes up sometimes is who should be making these. Should patients be doing these themselves? Should physicians be making these? And the parameters by the AADSM and AASM say that it should be made by dentists. And I think that if you've ever made many of these, you'll realize that you really have to understand what's going on in their mouth dentally to understand which devices to make. Now, once we make these devices, we should follow up with their sleep physicians and testing and so forth to make sure they're working well. And then we should coordinate follow-up visits. We should communicate with their physicians, and we should see our patients on a regular basis, because apnea is a progressive disorder. It gets worse typically with time, and we can't just hand them this device and say you're cured. We need to continue to see them, monitor this, and work with the medical community on doing so. So, so to answer the question we started off was, should dentists be doing this? Should we be doing dental devices? Yes. Should we be using sleep testing? Well, the ADA certainly says we should. When we talk about doing dental devices, we're going to be talking about that on February 13th. And these 5 devices are the ones that I would say, I know for me personally, 99% of the time, that's what we do in our office. And we'll go into details on when you use those and what the indications and contraindications are. So that'll be, again, on a Tuesday night.
Yeah, and I'm the guy with less hair there, the light shining off my forehead. I'm Rich Drake. That's my partner, Guy Yatros. We've been doing this a long time between us, and we love teaching dentists how to do this.
Yeah, and we teach a lot of dentists. We do webinars, as you know. We have consulting, a lot of things we can do. But I tell you, one of the best things for you, if you're wanting to get involved in this, is to come to one of our hands-on courses. We teach courses all over the country. We do a lot of 2-day courses. The 2-day courses, you get a dental device made for you, so you can actually feel it yourself. You actually get a sleep test done on usually we like the dentists themselves to do it. Do it usually the night before. We deliver the devices on the second day. And if you come, I really encourage you to bring your team too, because the team can do a lot of this, as we'll talk about. And I can tell you, you'll leave with the information you need to go back and implement this, and your team will be excited about doing this as well. And our courses are priced just under $1,000 for all that, but for people who attend our webinars, if you'll type in course, even if the dates aren't good for you here, we're adding more and changing some things. So if you type in course, we'll secure a $200 discount for you. Rich, coming up, you're coming to Florida soon, right? Here in a few weeks.
A couple of weeks away. We hope you guys can make it. We're just about sold out now, but we've got a pretty good lineup of speakers. I do want to say, Guy, that we really try to concentrate at this meeting on practical ways to implement, things that you can implement in your practice. Dentists, a lot of times, the Academy of Dental Sleep Medicine has a very good meeting, but it's kind of a higher level scientific type of meeting, and I like that, and I get into that stuff too. I'm not trying to put that meeting down, but ours is more of a nuts and bolts. This is how you do it. You'll take home a lot of things, and then another good opportunity to get your team involved in this more.
Yeah, and we had our weekly meeting on this. I think we have just maybe less than 2 dozen tickets left to that, so we're pretty close to sold out. So it's going to be a fantastic event. If you're worrying about your CE, you'll get it in your email within the next 24 hours. If you don't see it within 24 hours, check your junk mail. That's probably where it is. If you can't find it after that, certainly contact us. But you will be getting a CE for this tonight as well. When we talk about doing dental sleep, I hit the wrong button there. We really talk about the 4 pillars, what you need to do: screen, test, treat, and bill for your patients. If you have those systems in place to deliver those services, you're going to be highly successful in dental sleep. And they're just little steps you have to go through, and none of these are incredibly difficult. And through this webinar and other ones, we can teach you and your team how to do this with less than an hour of dentist time, while providing a life-saving, life-altering, life-improving service and increasing your bottom line in your office. Sometimes after these webinars, we get emails about what we do. We help you succeed in dental sleep. We help you with those 4 pillars, which the screening, testing, treating, and billing. And we help you through education, online education, in-person education, coaching, both online and in person. We have the best dental sleep software out there that allows you to quickly implement this, and we're available for support. So if you want to know more about what we do, or even if you just have a dental sleep question, type in consult, and one of our experts will get on the email or phone with you, and we can talk to you about what your challenges are, and we can also help you with those challenges, and then tell you how we can help you even more going forward. So type that in at any time. So we're going to talk about testing, in particular, the different ways, but I think we've got to get some definitions out of the way for some of you who may not know as much as the others about what we're testing for. I was going to let Rich talk, but I don't know.
Yeah.
I had to get my breath, so I was going to let you talk.
Okay, you were on a roll there, man. I was what you were saying. So, yeah, when we do a sleep test, Guy, what are we looking for? We're looking, do you stop breathing? Is your airway closing down partially? So we have all these things out there. So I know some of you dentists know this, but some of you out there don't know this. So when we talk about AHI, apnea hypopnea index, RDI, respiratory disturbance index, we're looking at how low the oxygen goes, and then we're kind of indexing these things per hour. So we throw around a couple of acronyms tonight. We're not trying to confuse you, but that's why Guy wanted to put this slide in here tonight, at this point, so that we know. So remember, in apnea, you're not breathing at all for 10 seconds. It's I'm trying to breathe, but I can't get air at all. That's what the flow curve looks like. I'm trying to get air, but I don't have any volume of air moving at all. So when that happens for more than 10 seconds and it's combined with an O2 drop, then we call it an apnea. Hypopnea is a little bit different. It's a partial breath. It would be like, instead of breathing through 5 straws, Guy, it's like breathing through 1 straw.
Right.
I'm still getting air, but I'm not getting as much air. So that can cause your O2 sats to drop as well. And now I'm disrupting my sleep. I'm doing something. So that's where we come up with AHI, apnea plus hypopnea's index per hour. And then the RDI just adds in something called a respiratory effort related arousal. It's not an apnea, it's not a hypopnea, but it's something related to your breathing that's usually disrupting your sleep staging with a concurrent oxygen desaturation. So, and a lot of the home sleep tests now, actually, you're using REI, Guy, the respiratory event index as well. So don't be confused by that. It's basically just how many times you quit breathing.
Yeah, so we went through those fairly quickly, and we can certainly help you if you have more questions about that. But we really want to get down to how you get your patients tested, and what we're looking for. Like Rich said, how many times an hour a person has trouble breathing, whether it's completely not breathing at all or just breathing barely enough that's causing them a problem. And so, regardless of whether we call it AHI, RDI, or respiratory index, we have a number of times we struggle to breathe an hour. And pretty much most people's standards, Medicare standards, are if you do that less than 5 times an hour, if you struggle to breathe due to airway constrictions, unless you're a child, we're talking about adults here, then we consider that normal, or at least we consider it not worth worth insurance paying to treat it. Mild 5 to 15 times an hour, 15 to 30, most people would say it would be a moderate category, and above 1 every 2 minutes, so 30 times or more an hour that we have a restriction, that's where we get into our more severe apnea. And those are just some definitions that most of you know. And, we can argue about this for the next 45 minutes if we wanted to.
It's not going to change anything, though, Guy.
It's not. These are somewhat arbitrary. We don't have these aren't lines in the sand. We're just trying to determine if someone's breathing well at night or if they're having some obstructions. And then we're going to treat them and see if that gets better. So, I think, I know we went through that fairly quickly. We wanted to do that quickly because we really want to get here to what do we want here? We have patients in our offices who are struggling. They're struggling to stay awake. They're struggling because they're snoring. Their spouses are having troubles. They're struggling because they have medical problems like hypertension they can't control and they don't know why. And we have a very good opportunity to help them. We need to help them understand they have this problem, and we need to help them treat this problem. But we have to have a plan. And I think that's where we shine at DS3, and also with a lot of our partners that we'll talk about, sleeptest.com and some of the other people we work with. We have the interest of our dentists and their patients at heart. And if we find systems to help them, it makes it fun for everybody and financially fun as well. And part of this, we can make all the systems perfect for you, and we can make it. We're going to show you, if a click of a button, you can get people sleep tested, but you still have to talk to your patients. You know, if we had a robot that would come in and cut a crown prep, I've never used this analogy because I'm making it up as we go. I don't think everybody just sign up. You still got to talk to your patients about the procedure and the pros and cons and so forth. So understanding sleep is important, and having someone in your office, and it doesn't have to be the dentist that does this all the time, that can sit down and map out this process, set out reasonable expectations. Hey, we're concerned about your breathing. I'm worried, Mr. Jones, that, you know, the reason your hypertension is so high and uncontrolled is maybe you're having an airway problem as we look at your anatomy of your neck. We don't sit down and go, hey, I think you have apnea, and I've got this new machine that'll tell us. We don't do that. The don'ts. We don't put the cart before the horse. We keep the patient's best interest at heart, and we talk to them about why we're concerned. And once they agree that, wow, I understand, maybe there's something going on at night, then we just need to talk to them about the various ways of getting them tested. And I think that's some of the key things that we help with when it comes to training teams and getting the verbal skills and the confidence, I think, as much as anything, to make those, to have those conversations.
Two things, Guy, I want to reiterate that you touched on there. Number one, express your concern. It's hard to argue with somebody when you're honestly and genuinely concerned. You know, you've got this guy, you got refractory hypertension, you've had a stroke, you fall asleep while you're driving, you know, I mean, all of these things, you're concerned, number one. Number two, try to create this sense of urgency, you know, because this is a big part about us as dentists helping get our patients to follow through with this. You know, we don't just say, hey, you might have sleep apnea, but I'll see you in 6 months, you know, and we'll clean your teeth again. No, you got to take a little bit of time. You got to use your words. Don't use big words, but be concerned and create a sense of urgency.
Right. And speaking of words, I see people are typing in some questions. Keep those coming. We are answering them as we go with our team. We will stay on and answer all the questions that you have about dental sleep that we can afterwards. So we'll stay with us. So keep typing in, and we'll get to all your questions. So, you know, I think once we consider that sense of urgency, and you're right, Rich. That's the most. I think if you're concerned, the patient feel that, and they know that there's a sense of urgency. No reasonable person wants to die in their sleep of suffocation or have hypertension or have all these things, you know, everything from impetus to a heart attack that apnea can cause, to fall asleep at the wheel. We don't want any of that. So once a person understands they're at risk for that, and that they can do something as simple as sleeping one night and being monitored to determine if they're at risk for that, I think most people will do that if you have that belief in there. And so in the past, when Rich and I started doing this about pushing 20 years ago, we didn't have two boxes here. We had one thing here. We had just this
one, and it was a big hurdle too, wasn't it?
It was this PSG. So, you know, we'll kind of talk to you like I talked to my 11-year-old son and tell you that you don't know how good you've got it because you've got options here, and we're going to go through them with you for the remainder of this webinar. And I think before we get into the details on it, I think pay attention to all the options, because everything that we're going to talk about, the different ways of getting our patients tested, we utilize them all on a regular basis in our practices. So there's indications for all the above. So, you know, we're not going to say only do this. I think you need to be familiar with the various ways of treating a patient. And this was option one and only one that we had when we started this.
For a long time. Yeah, and I think that scares some people, Guy. I think, you know, like Guy said, we use all of these options, but the PSG polysomnogram, you know, it's been the gold standard forever, and you know, and we're not so sure it is anymore. You know, because we'll talk about why that's the case, but we're trying to get patients to go get a sleep test. And this is one option. So now you know what it is. They hook up 30, 40 leads. You get an awful lot of data, and sometimes that's very good, you know. But look at the bottom right there on that slide. That, you know, we're looking at a lot of squiggly lines there. So we're looking at all kinds of things when we do that. The snoring, the video, the EEG. You know, I mean, I had a guy in the office the other day, who had a history of seizures. And we actually thought, you know what, we really think that a PSG is a better choice for you, even though it has a little bit bigger hurdle, but because of some of the health history and things like that. And that's where you said we use all of these options every day, but you're measuring an awful lot of things.
Yeah, just people in the other room. And so if the leads come off, they can put them back on. We measure brain waves and more things. But one of the big hurdles is you have to, in almost all circumstances, go to a facility to have this done outside of your home and spend the night in unfamiliar surroundings. And getting patients to even do that is a little harder than the other option, which is home sleep testing, that we'll get into in just right now, I guess. As a matter of fact, you know, this looks a little more.
I'm going to disagree with you there, Guy. It's not a little harder. It's a lot harder.
It's a lot harder. I mean, and one of the reasons that even Rich and I started our company was because of this difficulty in getting patients to say yes to getting their sleep test. And so we're going to kind of have a little argument or debate in a minute about which one's more accurate. But the jury's out, not out, the jury's in rather, on the fact that more people will do something along this line. More people will agree to be tested when they can put some equipment on in their own home, as opposed to going to a facility and having people monitor them and having to sleep in a foreign bed and so forth. And, you know, this has been around for a little over 10 years now. That it's been, and let me preface that, it's been around in so much as insurance companies have approved this, and it's been accepted by the American Academy of Sleep Medicine. Portable monitors have been around much longer than that, and in some other countries you utilize much longer than that. But in the U.S., finally around 2007, it became an accepted way to check for sleep disordered breathing or apnea, for someone to wear a portable monitor home under the guidance and diagnosis of a physician that reads that data, and then we can come back and get a diagnosis without the patient having to leave their house to do this. And so I think the big thing that comes up, Rich, well, which is more accurate? Is, you know, the PSG or more accurate? You got all those leads and people are watching you, and you're not in your own bed. Well, that's the other. You're not in your own bed. So does that make it more accurate? And something, you know, we've been using for a long time, and you know, I guess you can formulate your own opinion, is that a PSG, again, that stands for polysomnogram. This is the in-lab test. It has more data. It's a more accurate test of a less accurate night's sleep, because even though you're grabbing more data and there's people there, I mean, you know, to make sure that all the leads stay on and so forth, you're not going to sleep the same as if you're in your own comfort of your own bed, because it's different sheets, different temperature, different time you probably got to go to sleep. And I think one of the things that happens is people think, well, how's that affect your apnea? Well, it makes you have less apnea if you don't sleep as deeply, because you don't get to those deeper stages of sleep. On contrast, a home sleep test, you know, it may be a less accurate test. And when I say less accurate as far as having the amount of data, but it's a more accurate night's sleep. So if we sleep more normally, we're more inclined to get relaxed and get down to those deeper stages of sleep. And so really, which one's trumps what? We can use Trump tonight since he has a speech here in a few hours. But right. I didn't mean to slip that out. But which one is more important?
I don't think it really matters, Guy. You know, yeah. I'm just trying to get my patients sleep tested, and the bottom line is a home sleep test is good enough. Yeah, that's the bottom line. You know, it's good enough. And Medicare came out with this, you know, in about 2011, they started looking at this as an alternative. And what does it say, Guy? 40 million, you know, over a little bit, just a year and a half. So, right. sometimes you got to follow the dollar, right? Because
Right.
insurance companies want to, I believe that most of them want to provide a minimum level of higher service, but they also want to do it efficiently and save money. That's kind of what we want to do in our practice too, isn't it, Guy? So without beating them up too bad, we just have to look at the fact that the payers out there now say it's good enough and it's saving them a lot of money, and it's lowering the barrier to get people in and get them tested. So,
Yep.
Unless you own a brick and mortar sleep lab that you haven't paid off yet, most of this is good.
Yeah, and I don't even know when I even have my own biases that, and you say good enough. I think it's actually, there's quite a few times I find it to be better because the patient sleeps more normally, and I don't even know if I'd use the word good enough, because I think it's as good as would be the words I would use for that. And again, this slide's just showing the change in this particular geographic area in Massachusetts. Who made the decision? Well, the insurance company decided who was going to do the test, and they decided to do home sleep tests, and they put a few labs out of business in the process. So as Rich mentioned, we still refer people for PSGs. There are indications for that, and certainly if we're looking for any other sleep disorder other than apnea or sleep disorder breathing of some sort, then a PSG is most likely the best choice. But if we're just looking for airway, an HST is a perfectly good choice, and I say it's a better choice in at least one way that no one can really argue, is that more people will get tested if we utilize home sleep testing. And so there's a certain percentage of the population who will not go to the lab, no matter how good our verbal skills, no matter how good their insurance is, no matter what we say, we're just going to not get them to go. And we're going to test more people using home sleep testing. And so I think it's the future. It's just boomed over the last, 10 years or so ago, but over the last 3 or 4 years, this market's growing. And I think it's really helping awareness for apnea, and it's helping people to know they have this problem, and then it's helping provide patients for dentists and CPAP wearers as well. So that's why you're seeing an increase in the need, because the testing's become easier. So we're going to spend the next few minutes, or the majority of the rest of the time, talking about if you're going to use a home sleep test, then how do you do that? And we'll probably talk about those first two options the most. I mean, you can do the same thing you do with the PSG. So let's just make sure we're clear on the PSG. If you want us to refer someone to a PSG for a polysomnogram, you can refer them to their primary care and ask them to refer them to a sleep lab. Or if you have a conversation with the sleep lab, and there's a physician on staff, which there is, and you talk to them, can I just send patients directly to you that need sleep testing? And you'll want to have some discussions. As a matter of fact, if you come to the symposium that we're doing in a few weeks, that's exactly what I'm going to be talking about, though, how you have those discussions and what protocols you use. But you need to have a talk with the physician and how that referral is going to go. And then you also, really importantly, want to have a discussion about, if I refer you a patient, how are they going to come back to me? Because they'll take your patients a lot of times, but then you might not see them again if you don't have that second part of the conversation. So I want them to come back. Under what circumstances do we want to utilize a dental device? We like to go by the practice parameters. There's a lot that goes into that. So we can utilize the same method for home sleep tests. Some of the sleep labs provide home sleep tests as well. Some primary cares have sleep tests. So we can develop a relationship with the patient's primary care or a sleep lab that has home sleep testing, and we can refer them to the sleep lab. And the advantage to that is that we're working really directly with the medical community, and hopefully they'll send some patients back. Certain payers, such as Medicare, we're not going to get into big insurance, we did that last time, but Medicare does say they don't want us dentists really being involved too much in sleep testing. They don't want us ordering tests or utilize our own equipment, especially if we're going to be charging a patient for a Medicare device. So for these type patients, we certainly need a relationship to refer them to, and we can refer them for the PSG, or we can refer them to a physician for an HST. So again, the biggest part of that is communication, how we refer and how we get them back. So we're going to spend more time on, for those patients we want to be more directly involved with, with home sleep tests. And I think the first thing we'll talk about is you can order or you can buy your own unit and use it in your office. And there's a lot of them out there. Rich, you still have that top right one there, that Rimmers that made it through the fire, I think even?
I got 3 of them still.
That's like the first recorder ever made, right? Our good friend John Rimmers.
Been around for a long time. I do update the software, just so you know.
Okay. Yeah, so you can buy your own unit, and there's some advantages to this. There's a lot of different units out there that you can use, and I'm going to kind of go through some pros and cons with you. And I've had a lot of them. Actually, the one I just got trained on today, we just purchased this WatchPat, I can mention a little bit about the advantages to it, but they all have their pros and cons. And if we want to use one in our office to screen our patients and or get a diagnosis for our non-Medicare patients, depending on what state we're in, which we'll mention in a moment, we can do that. But we cannot, will not, should not make a diagnosis. Okay, we can use this to get the data. We can use it to work with our patients. And in many cases, we can send that data to a board-certified sleep physician and get a diagnosis. But we as dentists cannot make that diagnosis without involvement from a sleep physician along the way. And I want to make that real clear. Did I make that clear enough, Rich? Because I know we really want to hammer that home.
You did.
Okay.
So you can hand the patient your own home sleep test. They take it home. It comes back. You download the data. You send it to a service where a board-certified physician interprets it and then makes the diagnosis. So remember, there's a difference between handing the patient the test, but we're not looking at the data to diagnose it. We're having somebody else do that.
That's right. And now Medicare, just to be clear, says that we can't do that if we're treating Medicare patients. And there are a few state dental restrictions on that as well. And most of them don't have restrictions, but I'm aware of maybe a couple that do, so you can check with your state dental boards as to whether you can actually do that. But here's the big advantage about owning your own unit, is the patient's there and they leave with a test. I think that's the biggest advantage. If the patient's there, you have the test in your office. Hey, they agree. Yeah, I understand. I may be suffocating. Here, take this thing home. You hand it to them. They've got the test in their hand. The chances of them completing that test is much greater. Okay, so that's the big advantage. I think one of the other big advantages are, as they come back, if you learn how to use these, which there's a learning curve on some of them easier than others, but you can actually show them the raw data and you can say, look, you're breathing, here you quit. Some of them actually record snoring, and you can hear them snoring, and then you can hear them choking, and at the same time you can see their oxygen all messed up, going down, and heart rate going up, and it's pretty convincing. So that's some big advantages. You need a level 2 recorder. If you're going to get one, I like the ones that are less expensive per use, but I also like ones that work well, and I don't have to mess with it and redo them if they don't work well. So the one I just got was a little more expensive to use, but it has less chance of the patient messing it up, so that it kind of outweighs each other. You're going to have to learn how to use these machines, and one of the disadvantages would be if that patient's ready to go and say, yes, I want the machine. If you're doing a great job of screening your patients, your team may go to reach for it, and it may not be there, because it may be with some other patients, so you may have to have them come back and reschedule for that. But it's a great way to get started. Then you're going to buy, and I was going to say, the manufacturers of these, I know, have a solution to that. You can just purchase another one. I'm sure they'll be happy to sell you 2 or 3. And so, that's the advantages. The other thing I would say on this is that you have to find a physician to read these. And I would say, Rich, 5-6 years ago, that was a hassle. We had to find our own physician. We had to send it through HIPAA compliant portals to our friends that we would arrange. The vast majority of the companies that sell these, the companies hook you up with it. The one I just got, you just upload it to the cloud, you click a button, and and it'll send it to the board certified sleep physician in my state, and get a diagnosis and an interpretation from it. So you don't have to find these physicians like you used to. So really, some big advantages. I think we kind of went through those. I just dropped the slide in a little while ago. So there's some considerations. Yes.
Let me talk about the cons to that, Guy, because I have had these home sleep tests for a long time, and I've been using them a long time, and more staff and dentist time required.
Right.
and the learning curve. You talked about the learning curve a little bit, okay? But I've got to sit somebody down and say, okay, this is how you hook it up. Now, we have a video and we show them the video, but you still got to show them and you got to do that. They have to bring it back.
Right.
You know, then you've got to do that. So just from a logistic standpoint, it is a little bit of a pain. I think that's offset, Guy, because the patient's there and you go, here, take it home.
Right.
You don't have to go somewhere else. You don't have to go through 3 other doctor visits and all this other stuff. But like everything in life, a lot of what we're going to talk about tonight has a plus and a minus, and you just got to figure out how this is going to work best in your hands. And we're just trying to tell you that there are multiple ways to do this, and they can all work.
Yeah, and I'll hit a couple more cons as you said that. One, when they come back, you have to download it, and then you got to upload. It doesn't take long, but 5 minutes or so. But if they screw it up, and the reason I say the one that just got has a little less chance of that happening.
The pulse oximeter comes off.
Yeah, and then you look at the data's not good, then you've got to repeat the test on your dime, or charge the patient for it if you feel comfortable doing that, but they're going to probably object to it. So, so then you may have to repeat the whole process. And then some patients say, I want to do this. And even if you set the fee at a couple $100 or less, they say, I want my medical insurance to pay for this. And my suggestion is if you have patients like that, which we all do, then going with this next option where we work with one of the third-party home sleep testing companies is the best way to go, because they handle all that for you. The patient many times pays very little to nothing out of their pocket. So, you can work with the MDs, you can buy your own equipment, or, if you have DS3, we can plug ourselves here. Just click the button there that says, I think mine's hidden by the question box here, but order HST. And yep, there I can see it now. And you hit the button, and now that's gone. That goes to one of our preferred third-party HST companies. And there's a couple of them we work with. Sleeptest.com's one of them. Blackstone's the other one. They do a great job of handling all this for you. So you have DS3, you click a button, you send it to them. You can work with these companies outside of DS3. It's just a little more clunky. So to kind of walk you through the workflow, how much easier this can be, is the patient screen's at risk. So that we have that discussion, and that, we should probably put a big thing right in there, because that's the hard part, really. You've got to have team members who can convince the patient that, yes, I'll get a sleep test, but my gosh, I can do it in my own home. Yes, that sounds great. How much is it going to be? A few $100s or less. You have insurance? Well, they'll talk to you about, working that out with you. You hit the button, the home sleep test company, sleeptest.com, what have you, will call the patient. They'll arrange. They'll already have insurance information and so forth. If you're a DS3 member, they'll arrange for the shipment. It goes to the patient's house. The patient wears it. Instructions. If they have a problem, they have 24/7 support to help them get through getting it on, which most of them are self-explanatory. They put it back on. They send it back in the box it comes with. Now it goes back to the sleep testing company. The sleep testing company has physicians that read the data. They make a diagnosis, and in some cases, they'll even give you a prescription with some of the companies we work with. And now that information is uploaded right back into DS3, right to where we can see it, which I'll show you in a few moments. If you don't have DS3, you can still get the information, but it's just a little more clunky. So I click a button, and all that's handled, and it utilizes the patient's medical insurance for it. So, I mean, is that a little easier, Rich, than 15 years ago trying to get people to go to a sleep lab?
It's not a little easier. It's a lot easier,
right.
Like I said before.
You already corrected me.
And a lot of the cons of owning your own home sleep test unit that we just talked about are kind of the pros in this particular instance. Right. It takes less of our staff time, less of the doctor time. We can now spend more of our time, Guy, with our concerns and creating that sense of urgency so that the patient will follow through with the test, right? We don't have to do it. If there's a redo, the company's going to do it. The interpretation is already included. Man, it shows up in the software. It's like I turn my software on tomorrow. I log in. I go, hey, look, Guy had his sleep test done. Right. Oh, here's the numbers. So a lot of the downside on owning your own unit is a plus side for that. And then the downside of the third party that you list here, Guy, you go through those.
Yeah, these really, most of them, in most cases, are not a concern. I'll say jump to the second one. You know, if they're Medicare patients, then we have to be more cautious about this as far as needing a signature for even titration. So we'd have to get the primary care to order it. Even from these, we can still utilize these the home sleep testing companies, but they have to get the order from their physician. It can be more or less on this slide's a little old. In most cases, I would say that it costs the patient less the majority of the time than if you do it yourself, because you're going to have to charge that patient for some of your time and effort and for that equipment cost. And then most of the time they utilize the patient's insurance, and out of pocket for the patient typically is less. In some companies it could be more, but not the companies that we typically work with. And third bullet point, we gave you a couple of good companies. There are some companies that we've worked with in the past that we've not had great service. So just like any other service out there, you got to get a company that does a good job, and we've got two excellent companies that we work with. You know, if you're doing this in your own office, you can say, all right, I'm going to charge you every time we do this test that I hand it to you, and there's no limit to that. But if you're utilizing a medical insurance, maybe 3 tests a year, but I've heard that that's really not even true. It really, if we can justify the reason, then these sleep testing companies can get this done. The only real negative that comes up, and I put it on this cons list, although Rich, I think it's really on how you handle this, is the medical community can give negative opinions, and I really don't think that's really true, but it's a concern. Many people, well, is my doctor going to be mad that I did this? Is the sleep lab down the road going to be upset? And if you handle that correctly, and I'll talk about this at our symposium when I'm talking about working with sleep physicians, that's really a non-issue. As a matter of fact, it becomes a positive issue, because what we're doing is we're finding patients that have not been diagnosed, that have fallen through the cracks. There are people coming in to get restorative care in our office, and now we're getting them tested. So we're bringing new tests to diagnose patients to the forefront, and some of those need CPAP, and we're going to be referring some of those to that same medical people that you're concerned about. So if you manage that correctly, I would even say it's not a con. You could even move it over to the pros if you do it in the right manner.
That's the key part that you said, Guy. You got to do it in the right manner. So remember, it's in how you handle this. You know, sometimes a physician, you know, I use the example, Guy, when I do this with a primary care physician, I always say, just like you said, a normal patient, when you talk about all these bad things with sleep apnea, a normal patient would want to get tested.
Right.
Right? Well, most normal primary care physicians would say, thank you for taking that off my plate and doing that, you know. So you got to remember just to be careful about how you handle it. And I'm looking forward to hearing what you have to say about that at the symposium, Guy.
Yeah.
But I do think that it's very, very important. I mean, if you take away a couple of things from this talk tonight, one of them should be that you show concern, you create that sense of urgency, and you kind of talk the patient through what's going to happen. You're going to get the test. We're going to click this button. The insurance, you know, the Blackstone homesleeptest.com is going to call you. They're going to go through this. They're going to give you what your cost is as best they can estimate it. And then you're going to come back here and we're going to talk about the results. And we're going to figure out what is the best treatment option for you at that point. You've not put the cart before the horse. You've not told them they already have sleep apnea. You're not trying to sell them a dental device, but you're trying to set realistic expectations about how this is going to happen.
Yeah, I'll add one thing. When you say you're going to come back and talk about it, once we explain the process and they agree to this, go ahead and make them a follow-up appointment.
Absolutely.
About 3 to 4 weeks, depending on the patient's schedule. Say, so you're going to, how this is going to happen, then you're going to come back in and we're going to sit down and go over this. Now they're committed to it. That way they're not going to
accountability.
Absolutely. Because we work with sleeptest.com a lot. I just talked to them a week and a half or so ago, and one of the challenges they get is they ship the unit out and the patient leaves it sitting there on their shelf. And we got to create that sense of urgency because the patient left motivated. But I leave every morning thinking I'm going to run 100 miles maybe before the day's over or something, and it doesn't always happen. We lose our motivation. So put that sense of urgency in there. All right, so what other reasons are we going to do this? So we talked about the various ways of doing this, but we want to kind of finish off, and we're going to get to all your questions before the night's over, which we'll be finished on time.
We're doing good, Guy. I've been looking through them, and we're being answered, I think, very well. But remember, we're talking about so far. We've been talking about on the front end or the diagnosis side. Right. So now we're going to switch, Guy. Right? What happens after we make them a dental device? What do we do?
Yeah, well, we want to make sure that their symptoms are under control, make sure they're wearing the device. So, I mean, that's we hope to make them sleep better and feel better. That's part of our goals. And if they're not wearing the device all night long, then there's no sense in going further. We need to start with that. And then once their symptoms are better, we have a whole system on how we track their symptoms through DS3, which we will be happy to explain to you if you want to take more time and talk to one of our team members. But once we establish, yes, the patient's doing better, they're wearing it all night long, we need to make sure that those numbers, that AHI and all the things we kind of breezed through at the beginning are doing well, and that they're actually getting air down to their lungs and they're not putting themselves at medical risk. And that's what we call a titration study. And you can do this on one night, and then if it's not what we want, we can repeat it, or we can do it on 2 nights or even 3 nights. Most devices will do 1 or 2 nights. Some of them will do it on 3 nights. But if you use a DS3, one of the things that we really do, I think, that make this easier is, a sleep test might be 1, 2, 3, 10 pages long, usually 3 to 4 on average. And we got to look through there and find all those numbers at AHI and all that stuff. Well, if you use one of our HST companies, when you get the patient tested, it comes right back into DS3 with all the data, easily arranged, and a copy of the test that you could click on if you want to view it. And so at a glance, we could tell this person has almost 30 events an hour, and they're really worse in the supine, and their oxygen levels are dropping down. And so that was their baseline. Well, if we did a 3-night test with one of our partners and the data comes right back into DS3, we can see here's where we thought they were doing better, but we moved them a little bit more forward the second night and even more the third night. And we can even see, wow, this third night is really where we want to be because the AHI and those numbers are where we are very happy. Oxygen readings are good. And you can do the same thing with 2-night tests as well. And having a system like DS3 where we can compare 1, 2, 3, 4 tests in a row without having to lay them out across the desk with 4 pages each to try to make sense of them really makes a difference. And when you can do that by clicking a button and that data coming right back in to DS3 and displayed in such an easy manner, it could take a matter of less than a minute to make a decision here, probably seconds, even 20 seconds we can make a decision at this, as opposed to, Rich, if I had you 4-page sleep studies and tell me here's the baseline, here's 3 follow-ups. How long is that going to take you to dig through that and to make a decision?
It takes me about 5 seconds because I go, hey, Pam, will you sort all this out and then put it into the software? I feel like I'm talking to your son, Guy, and I go, hey, you don't know how good you have it.
Yeah, so, right.
Just the fact that it comes back and it's in there, you don't know. It takes a lot of staff time to look through those pages, put the numbers. I mean, when we just hired a new assistant in my office, Guy, we're in the process of teaching her how to do this. Right. So she gets a sleep test. What am I looking for? Where is it? What's the AHI? What's the RDI? So it does take some staff time. So the fact that when you use DS3 and you do that through these home sleep testing companies that we work with, that saves you an enormous amount of time. And it just, like you said, Guy, you don't know how good you have it when you do some of this stuff that way.
Right. And our goals of treatment, I had the slide up there. I'm not going to spend much time on. Our goal is to get the apnea cut in half and as low as possible, ideally less than 10. But I mean, I hesitate to leave that up any longer than that because there's many times where the patient's doing great, their apnea went from 40 to 12, and I'm thrilled to death. They're thrilled to death, and I think it's the best treatment for that particular patient. So, one thing I thought I'd throw this slide in, and we haven't looked at this one in a while, Rich. And I've done a lot of things in dentistry. I've been a dentist for about 30 years, and I practiced in Eastern Kentucky and extracted teeth for a year. I had a nursing home that I had 9 of them for a while. I worked for pediatric dentists for almost 2 years. And then I started my own office. And as I grew my office, I decided what I liked to do and restoratively, and it was implants and some real complex prosthetics that I liked. And, and as I learned to do different things, someone along the way talked to me about the stages of learning. And I think it's worth talking about, because no matter what you're doing, whether you're driving a car or doing implants, you're very likely to go through these stages. And when you do your first implant, it looks good, you think everything's great, the patient's not complaining, and you think you did a great job. But maybe you cemented the thing in 3 millimeters below the gum, and you didn't realize that 2 years later down the road, that may cause a periodontal problem. And so you were unaware and incompetent. So, but that's okay. You're unconscious competent. So you're happy. I did a great job. I went home feeling like $1 million, but then that guy comes back 3 years later and we got a problem. And now I'm conscious incompetent. I realize that I didn't do something well, and I better start doing it better. And I try to become better at what I'm doing. And if I try real hard and I learn how to cut crown preps or implants or whatever you're working on, and you try and study and get the advice you need, you can eventually get to where you think about it and I'm doing it well, but I have to concentrate on it. And eventually, if you really master something, you get to what's called unconscious competent, which is the 4th stage of learning. That's where you drive a car, or Rich, in your case, drive your boat and catch bass without thinking about it, right? Because you're just so good at that you don't even have to think about it, right? You just they just jump in the boat when they see you coming, right?
I'm just that good. But that's certainly where we try to get to. You're right.
How we get. And my point by bringing this up, if you're thinking about doing something else in your office and you're wanting to expand your office, do more services, make more money, help more patients, you can go through this curve, because you got to go through the curve no matter what you're doing, much quicker in dental sleep, because especially if we help you, because we've got these systems figured out. And it's just a matter of following a manual, following systems. You don't have to learn how to cut a crown prep. We teach you how to walk through each of these steps, from screening, testing, consult, exam, delivery, follow-up testing. And we not only teach you how to do it, we can teach you how to do it in a very small amount of time for the dentists themselves, once they become masters at dental sleep, which doesn't take near as long as it does to be a master at many other things in dentistry. And so you can be doing this, and your team can be handling a lot of this in the background while you're still even doing all those other things, just like I did in my office. I did restorative dentistry until 6-7 years ago, and we were doing rehab case in one room, and we were doing consults and impressions for dental sleep in the other, and you can become just add a whole nother profit center to your office. And look at this, we're not making these numbers inflated at all. If you're just getting an average amount of $2,500 a case, which I would tell you a lot of people use a lot bigger number than that, but we're trying to be very realistic. You have a lab fee, it's reasonable, $350. If you pay someone else to do your insurance for that, and even if you pay for DS3 for the year and you do a device a month, you're adding, pushing $20,000 to your, just in your pocket. And if you do one device a week and take 4 weeks off, you're pushing 6 figures that you're adding to your dental net. I mean, that's not, there are not any really other large expenses in there that you have to take out. So you're adding to your bottom line while you're helping your patient. So I know we're getting to the questions, and I think some people typed in consultation. What we mean by this, if you are interested in dental sleep in your practice, or maybe you're doing some and you're having some challenges, whether it's a TMJ problem or insurance billing, and you want to just talk to us on the phone, that's what we do. We answer questions, we help you with your hurdles, we give you systems to do dental sleep, and just type in consult, and someone from our team will meet with you, likely Jody or Brandy, and we will first of all help you and answer your questions, and second of all tell you how we can help you be more efficient at what you do when it comes to dental sleep. Did you see this yet, Rich? Our Insider came out today.
I did. I even got a sneak peek yesterday. So,
yes.
Man, I love this. If you guys, it's free. It's insightful, informative, all like it says right there. We have various contributors every month. A guy usually does some kind of a video, shows you how to do something on a device, or, do something like that. But we have a lot of contributors to this. And again, it's all kind of geared toward nuts and bolts, how to do this kind of stuff, and it's free.
It's free. And again, we have our courses that are coming up. If you've got on a little bit late, which we apologize again, I think it's the first time we've ever started late on one of these webinars. Apologize for that. If you didn't hear that part, we have courses all over the country. They're less than $1,000. You can get $200 off to come to the course just by typing course. Doesn't obligate you to one of those dates because we can work with you on one of the dates for our courses. I teach most of those. Rich teaches some. You will leave there thinking it was well worth not only the money, because the money is very minimal, but your time. I think you'll leave there saying you learned a ton. So if you type in course or consultation, we will get back with you. There's some of the course dates were added more to this as we're going. So be sure just to let us know if we have that. And I think we've got one more reminder. February 13th, we'll be talking about these devices, where you use them, when, why, and how, pros and cons, which ones hold up better if the dog gets a hold of it, everything like that. So look at that. We started a couple minutes late. We finished on time. I think we're happy to stay on answering any of the questions. I know, Rich, you've been managing a lot of these questions, and our team has. Do we have questions we need to answer?
Well, there were a couple on Medicare patients, when we're talking about home sleep testing. So remember, Medicare requires a face-to-face with an MD. A lot of places you can do that remotely, with telemedicine. So there are some cutting edge things out there that you can certainly look into. But again, your state dental board can give you some ideas about how you do some of this. But remember, with Medicare patients, they're such a different beast. We could talk for a couple hours about how you deal with Medicare patients. Be careful, number one. But I think, Guy, just remember, they need a face-to-face with the MD, and let the MD order the sleep test. It's just the easiest way to do it. Can you do it? Yeah. But remember, Medicare says you can't profit from the sleep test and the DME. That's what the physicians used to do. They used to own the sleep lab, and they also owned the DME company, and Medicare didn't like that. So they're not going to let us as dentists get into that. So you can't profit from both of those. That's a 2-hour conversation, but just make it clear, Guy, that face-to-face with an MD for Medicare.
Right.
There were a couple of things about cost and that kind of stuff. I mean, what do you charge for these, Guy, when you do let's say you have your own, you just bought that WatchPat. What are you charging the patient for a titration home sleep test?
Yeah, so that's a great question. And if we're talking about titrations, we discuss how the patient's going to be tested for titrations at the consultation. So
why is that important at the consultation?
So we're talking about titrations here. I think I'll talk about briefly for diagnosis as well. But for titrations, it's important for 2 reasons. One is to set the proper expectation for the patient so that they will get a titration study regardless of the cost. So, the second reason is cost, so they can expect a cost and who that cost is going to go to. So sometimes I have a physician that refers me patients, and he's a sleep physician, and he wants all his patients to go back for a PSG. And if I don't get him to come back, he'll quit sending me patients. So you know what? We have that discussion. You need to go back, and you're going to have another in-lab test when we're finished. Now, I'll include maybe an oximetry test, maybe one of a WatchPat test or something in between, and I have to consider that in my overall cost of treatment if I'm going to do that. I don't like to charge for the test if I'm going to do them at the time of the test. I like to include it in my treatment cost. That maybe it's just my personality. I don't like to be nickeled and dimed. I don't like open-ended agreements. And this way, look, here's the fee, and it includes us doing a follow-up test, or it doesn't, because a lot of times it doesn't, depending on the patient. For diagnosis, there's 2 ways of doing that. One argument is, look, just give them to them for free. Eat the cost of the equipment, eat the cost of the per use, eat the cost of even paying the physician if you want. Because if you do 2 of them, one of them goes ahead of treatment, and you make it up. I don't. That's not the way I typically believe in doing that. I'll do a free consultation to discuss it, but then we'll charge them a fee if they haven't had a test, a fee that will cover the cost of the expendables for that equipment, the cost of my team's time. One of the reasons I just purchased this WatchPat was it takes a lot less time for them to upload it and download it. It's just easier to hook up. And and then the cost, but it's a little higher cost per use. So, that kind of offsets. So I got to get that cost. And if I'm going to send it to a physician for an interpretation, which we are if we're doing a diagnosis, I got to pay that. So I add all three of those up and a little bit of profit, and you come up with a figure. Most of the time, that figure is going to come out between around a few $100s in most offices. So I hope that answered that particular question.
Oh, that's good. Dr. Stephen G is asking about cost of a device. I think that's probably something, Dr. G, we should have confidentially. We can't get up here and talk about what we should charge for these things. Most dentists charge about what they charge for full upper and lower dentures, just to give you a ballpark start. Right. Wouldn't you say, Guy, about that?
Yeah, and we put a fee of $2,500 in that return on investment, and I think that's a I think a conservative amount of what dentists can collect doing a dental device. Now, we attend one of our billing webinars because understand in medicine, we don't always have as high a collection as we do in dentistry. So in other words, if you collect $2,500, if you have a 80% collection, then you're going to have to charge more than that to get to that same number. So that's a whole nother topic, and we'll be happy to address it. And again, type in consultation, and one of our team will get on and talk to you about that as well, because that's what we do all day long. What do you do when a patient comes back with severe apnea? Okay, John, we'll answer that. Well, since you're willing to stay on with us, and we're happy to answer it. If they have severe apnea, the American Academy of Sleep Medicine, the AADSM guidelines say that they should try CPAP first. Most insurance companies have a similar rule. So for two reasons, we recommend CPAP first if they have severe apnea, because number one, medical insurances likely won't pay for the procedure. If the patient absolutely refuses or says, I can't stand to have a CPAP, I won't try CPAP, or if they try it and can't wear it, then we'll make them a dental device all day long. But we let them know that the standard is severe apnea. The recommendation is to try a CPAP.
Yeah, they should at least consider and try. So I answered one of those questions earlier again. I said, that's a really good question. A lot of it just depends, Some people just say, man, there's no way I could wear that. There's just absolutely no way. And we get them to sign something, and we'll get by insurance in that particular instance. But I think it's our responsibility because the guidelines are pretty strong in that for severe, we should at least steer the patient towards attempting CPAP first. And I think that's a reasonable thing. Yeah. And I'm wondering if Dr. John wasn't asking, when they come back for a titration sleep test, if they still have severe. So you handled that on the front end. On the back end, if you do a titration sleep study and they still come back and they're severe, well, obviously we haven't titrated them correctly. We're going to need to move them out. Sometimes we even move them back. We add a little vertical, we add elastics, we do a couple of things like that.
We'll be talking about some of that in the next webinar. And there is sometimes where dental devices are non-responders. And sometimes we say this is as good as we're going to be able to do. We might have to look at other treatment alternatives in that case. Another question on here is the auto reading opposed to the MD, is that accurate enough? Well, my answer to most things, if you come to one of our courses, you'll get a lottery card if you answer the questions. And the answer usually is it depends. You can never go wrong with it. The answer is it depends. And yes, the auto readers work well. Some of them better than others. Some devices better than others. And so, can we use those for titrations if you're comfortable and you understand enough to do that? But understand, even if I use my own equipment for a titration, and I don't send it to the physician, I'm just looking for my own benefit to see if I feel like I've got the jaw. I'm comfortable reading those results. I'm comfortable directing the jaw position. But the last thing I do when we're finished with that patient is I send their physician a letter. And through DS3, I just click. Every physician that they see that gets the same letter saying, we've done what we think is the best we can for this patient. We've got their jaw and what we consider the maximum medical improvement with the dental device. We're referring them back to you for further evaluation and testing as you see necessary. So I'm giving them back to the doctor saying, I've done everything I can here. If you want to do further testing, you can, because I don't think I'm comfortable saying that they don't have apnea now with their device in place or what have you. So for titrations, yes, we don't always, that's kind of a double negative. I don't always use the MD interpretation for titrations, but I always refer them back to an MD who may want to do that.
For the final one, yeah.
Right.
And that goes all the way back to one of your first slides, Guy, with the ADA. The ADA says we can use home sleep testing to get our device dialed in, and then as long as we do exactly what you said.
Right. And one thing I'll mention to these questions on here, part of the DS3 membership, Rich and I not only do this about every 2 to 3 weeks, every other week we have a webinar that we open the mics up to. These are DS3 members. It's a big study club meeting. We usually have a few dozen dentists on, but they all are experienced now at using their microphones, and we can unmute everybody. And these are the exact kind of conversations that we have with our members every other Wednesday. The questions you submit, it's member driven. So whatever our members want to talk about, Rich or I get on and we talk on, those are on Wednesday nights at the same time, and it's fantastic. It's a great forum if you're the kind of dentist or dental office, even for team that want to have a kind of a study club learning sessions. We do those twice a month for our members.
And I'm kind of typing this in now, Guy, but I think it'd be easier to say the thing about does the DS3 system have something that funnels patients towards a sleep doc? And the answer is no. That's on you. That's what Guy's going to talk about at the symposium. He's going to talk about that relationship that you have. So if you have a patient you screen, you actually get them tested, they're diagnosed, and now we want to get them CPAP or we want to do something like that. That's what Guy's going to talk about, where we have to establish these relationships. You know, sometimes it can be as simple as picking up the phone and calling their primary care doctor. Hey, we need to get this guy CPAP. You know, sometimes we need to funnel them towards a sleep physician. So that's a really good question, and it, like Guy said, it depends.
And I wouldn't say the answer is no. You do get listed on our website for DS3 members. You will get calls from that. We do provide you with a marketing material, posters to put up in your office, a screening system, a cloud-based screening system helps screen your patients. So we help you find these patients. I mean, I think the answer to Rich is saying, do we go out and find patients and send them to you? No.
No, I was under the impression, Guy, that the question was, does our system funnel the patient to the sleep doc? No, I could be. You're reading it right. I might be reading it wrong. I'm sorry. That's why we like. But that's good that we're covering that kind of from both ends. You know, we're like Guy said, our system, you get put on a website, you do that. It helps the sleep doc find you. That's always been my challenge, Guy, for 20 years. You know how many times I have a doctor say, "Man, where have you been all this time?" I'm like, I'm still here. I've been here for 20 years. You know, how can you not know about me? But that's a common problem, though, isn't it? They don't know about us, and we need to get out there and
yeah. So it will help teach. So Rich, I apologize. You read it right. I didn't. But that's what I will be talking about at the symposium. But we don't just limit that to the symposium attendees. We help you understand how to handle your severe patients. We help you have the verbal skills, scripts, tools, coaching to be able to know what to do with those patients once they're severe. So you're not going to be left out in the cold. I mean, we're there to hold your hand. We will help you with as much as it's kind of like a all-inclusive gym membership. You know, if you utilize us for everything that we have, you're going to have all the help you need to put your dental sleep practice into shape. And so we're there for you. But no, we're not going to go drive from Florida to wherever you live and meet the sleep physicians for you. Okay. Well, great. Thank you, John. I'm looking forward to come up and say hello, John, at the symposium. We're welcome aboard to DS3, and we're looking forward to meeting you there in a few weeks. So I think it's 9:13, and my 11-year-old is going to be coming walking through here to go to bed any second. So I think
we apologize again for not starting on time. Thank you guys for telling us you couldn't read our lips for the whole hour.
That was my fault. So we'll hope that won't happen again. After doing probably hundreds of these, I think it's the first time that particular thing has happened.
We're human, Guy. We are still human. That's right.
Yes, we are. Well, thanks everyone. We look forward to hopefully talking to you on the 13th. What I think was the 13th is the devices.
Devices, yeah.
Yeah, so we'll talk about that then. If any in the meantime, feel free to contact us at DS3 if you have any other questions we can help you with. All
Have a
right.
good evening, guys.
Good night, Rich. Good night, everybody.